This program is brought to you by McGill University. Please visit us at www.mcgill.ca.
Thank you. Thank you. Thank you all for being here. Thank you all, so many of you here. How many people do we have? 110 people here to listen to me talk. 120 people, 110 people just staring at me right now. It's okay, I'm a professor. Been through this before, right? I can handle it. It's okay. They can't ask questions. Can they ask questions? They can ask questions. Okay. What if I don't know the answer? I don't know. Okay. So let me think out loud for a second here. I have two options. I can give it a shot. I can go ahead with this talk. Might be okay. Might be great. Might be the best talk you've heard all year. Best talk you've heard in your life. Standing ovation, applauding. People screaming my name, maybe fainting. I don't know. Just like with Elvis, right? My moment of glory. Or it could be not too good. It could be a complete catastrophe. Next time I walk across campus, people might say, look, there's that professor there from McGill who gave that lousy talk. Let's all get him, eh? And I just noticed the camera up there, so probably this is going to end up on YouTube, eh, with all those other bloopers. And tomorrow morning, you can just go on the internet and type lousy talk, professor, McGill University, complete and total humiliation, and then this video clip will show up. So that's one possibility. It's a 50%. It's a gamble. Might go well, might not. The second option I have is I could, is I'm free. I don't actually have to be here right now. I could leave if I wanted to. You see there's an emergency exit for professors who chicken out right there. You can't see it, but it's right on the side. For professors and lecturers, I could ask Sue, Professor Lajoie, who's the chair, who's known for her great sense of humor most of the time. I could say, well, why don't you tell him a joke or two? And as she's doing that, I can just sneak out through the back and, of course, never come back, right? The problem, if I do that, is I'll never know if I made the right decision. And that's the problem with fear. If you choose to run away, you never know if you made the right decision, if you made the right move. If you cross to the other side of the street because there's someone walking towards you with a dog, maybe it was a wise decision. Maybe that dog would have bit you. Then again, maybe not. There's no way for you to know. There's no way for you to predict. But what will happen is chances are next time you do see someone walking your way with a dog, you will cross to the other side of the street again, just in case, right? Now, I want to get something straight right now. Fear and anxiety, that's normal. You're supposed to sometimes be afraid, and you're supposed to sometimes be anxious. It's a natural response to a stressor. It's a natural response to a danger. It's basically our body's way of telling us we might just feel out of control and we have to be hypervigilant. So what happens? Our hands get sweaty. I'm not sure what that achieves, but they do get sweaty, right? Our heart races, our mind is racing as well. We're ready to bounce. We're prepared to handle the situation. Now, I did research in prison. I was a researcher there, of course, not an inmate. I did research on the treatment, the efficacy of treatment for sexual offenders. And this is a prison located up north. In a small village called La Macasa. It's a federal penitentiary, so these are people who are in jail for 2 years and more, a lot of sex offenders and a lot of rapists as well. And in this prison, they had a clinic. So the way it was set up is you would have this large field. It felt like a very large field, and you would have to walk across this field to get to the clinic. And one day, as I was walking to the clinic, a large, scary-looking inmate with tattoos and a shaved head and biceps the size of watermelons started walking towards me. And of course, I decided not to run away, of course, because I'm not a coward, right? I froze. Okay, I'll say it. I just froze, and I couldn't do anything else, right? I did, however, take my best kung fu position. I'd show you right now, but it's right. And he hesitated for a minute. He looked at me, but then he continued walking towards me. And it turns out all he wanted to know where's the clinic? He was new, you see. Now, a response like this, fighting, or being prepared to fight, is a natural response, just like flight, running away. Those are the two main reactions we have when we're faced with danger. I'm still convinced his original intention was to mug me or attack me somehow, and then he just shied away because of my tremendous, amazing display of martial arts. Both of these, again, are normal responses to stress and to danger. And without this kind of anxiety, without this kind of fear, our response to a situation might be inadequate. It could be this talk, for example. I had to prepare for a talk in front of 120 people looking and at me and listening to me. If I hadn't been anxious about it, I wouldn't have prepared. Same when you're driving at night on an icy road. If you're not slightly anxious, you're not going to be as vigilant. Right? There are times, however, when one's response is simply out of proportion, right? Where you're not actually responding to a natural danger. You're responding as if there was a danger, but there is no actual danger. And that can be extremely disabling. So there are times when, or there are people for whom, for example, this spider right here in the middle of the screen, can you see the spider? No, can't see. I'll point it out for you right there. See the spider? No, okay. Did you really think you could actually see a spider? No, this is Quebec. We don't have big spiders. We have small, puny, itsy-bitsy little spiders. Yet, for some people, this spider that you see on the screen feels like this, right? Yuck is right. And there are people for whom changing a light bulb just 2 feet off the ground, right, feels like this. And there are people for whom even happy people, pleasant people, feel like this. In other words, you should avoid them because you never know what might happen. Right? Now, in those situations, we can no longer say that it is a normal, anxious response to a stressor. It's blown out of proportions. So when you have an anxiety disorder, and that's what we call them, an anxiety disorder. When your reaction is out of proportion, you have an anxiety disorder. And when you have that, your body and your mind reacts the same way as if you were face to face with danger, but there is no actual danger. Your body reacts the same way. Your heart pounds, your mind is racing, your palms are sweaty for obscure reasons again, and you're ready to bounce, but there is no actual danger. If you have an anxiety disorder, you can't stop yourself from feeling afraid or anxious, even though you very well know that you shouldn't be afraid, even though you very well know that your reaction is out of proportion. And once you've experienced this kind of anxiety, you usually avoid whatever you believe triggered that feeling. So whatever scared you, or whatever you think scared you, is something you're going to, in the future, begin avoiding. Obviously, for these reasons, having a true anxiety disorder is extremely disabling, right? People who have an anxiety disorder, it gets in their way of their everyday life, professional life, family life, building relationships, meeting new people. It gets in the way of relating to the people around you, your friends and family. It gets in the way of you being successful at work or at school. And more importantly, anxiety disorders are highly comorbid with depression. So if somebody does have an anxiety disorder, chances are they're also going to suffer from depression. Now, we have different ways of coming up with a diagnosis of an anxiety disorder. We have different manuals that we use. One of these, the Psychodynamic Diagnostic Manual here, which contains all mental disorders. If you get a chance to look this up, get your hands on this. I'm in chapter 3, as a matter of fact. It's all about me. We have another one, perhaps more popular. It's the DSM. Everyone's heard of the DSM. If you've had dealings with a psychiatrist or a clinical psychologist or a counseling psychologist, and they have to come up with a diagnosis, this is what they use. Now, in the DSM, there's an entire chapter about anxiety disorders. And there are many different anxiety disorders. Panic disorders with or without agoraphobia. Agoraphobia without panic disorder. Social phobia. Obsessive-compulsive disorder. I'm sure a lot of you have heard of OCD, obsessive-compulsive disorder. The common example is the person who just continually, repeatedly washes his or her hands and just can't stop, or turns the light switch on and off, and then turns it off to make sure, or turns it on to make sure it was really off, and then turns it off to make sure it was really on, and then off to make sure that it was really on, right? Turns on in the oven to make sure that it was really turned off appropriately the first time. That's OCD. PTSD, post-traumatic stress disorder, which is something that's that we find highly prevalent in, for example, soldiers who come back from combat, right? So those are nightmares. People have trouble sleeping, and then they relive the traumatic events in their head repeatedly, and they become extremely anxious. Acute stress, and then generalized anxiety disorder, substance-induced anxiety. There's plenty to choose from, to be honest. And the one I'm going to focus and talk about tonight is what we call the specific or the simple phobia. Okay? In many ways, I think the specific phobia is probably the least disabling of these anxiety disorders for a simple reason. Most of the time, you can avoid what makes you anxious, right? I have a friend who's afraid of bridges. This goes back quite a while back. She told me once that she was afraid of bridges, and of course, she can't drive onto a bridge, which is a problem if you live in Montreal, because it's an island, right? She was fine in tunnels. She can drive through a tunnel, and that meant that no matter where she was heading in Montreal, South Shore, east, west, south, north, she had to go through the tunnel, had to avoid the bridges. So you can imagine the detours that meant sometimes, right? It was extremely, extremely time-consuming. Now, if someone else was driving, she could handle it. So we were driving, and we were about to drive onto Champlain Bridge, and she tells me she's afraid of bridges. And so what do? Of course, we drive onto the bridge, and the first thing I say once we're on the bridge is, God, this is so high. Huh? Did you look down? Hey, the water looks so cold, right? It was not the smartest thing to do, was it? Huh? But somehow that's what I mean, I can blame it on different things. I was young. I was a student back then, to be honest. I could say I was young and naive. Today I know better, obviously. I wouldn't do that. Not to someone I like, at least. But there's another reason why I did that, is because the word phobia is so common today. We use it in our, weekly, in our common language to describe not a real phobia, but a dislike. And we sometimes forget that people who have a real phobia have a real anxiety disorder, and it's extremely disabling, and they're suffering, right? We forget that again because the word phobia is so common, and we use it basically to express a dislike. It's not a phobia, it's an actual dislike. An example, homophobia, right? We've heard the term, a dislike of homosexuals. Xenophobia, a dislike of strangers, right? We use these terms. Pantherophobia, no idea? Dislike of your mother-in-law. Hexacosia, hexaconta, hexaphobia. Anyone take Greek in school? Yeah. 666, a dislike of the number 666. Now, this is something you want to use at a cocktail to impress guests. And the worst of all, of course, panophobia or panphobia, which is basically a dislike or a fear of everything. Okay? We can laugh at this because they're actually just ways of expressing a dislike. When you have homophobia, you do not pass out when you talk to someone who's gay. All it means is potentially you're prejudiced. That's what it means. If you have Pantherophobia, it does not mean you have a panic attack, a real panic, at least not normally when you meet your mother-in-law. What it means is that Christmas dinner is probably painful, or she does not have a key to your apartment, but it does not mean that you have an actual anxiety disorder. You do not have a panic attack. It's a very simple game, to be honest, when you want to express a dislike instead of an actual phobia. You just take the word phobia, and you take another word, just slap it in front of phobia, and then you have a new phobia. Preferably, you can use the Latin root of the word, right? So you'll have, these are phobias that start with an A. Okay, so you have a chirophobia, for example, a dislike of insects that cause itching, right? Or a serophobia, a dislike of sourness, right? And then you can go on. Basically, there are as many phobias, if you take it in this sense, as there are objects in the world around us. In psychology and in medicine, when we use the word phobia, it has an entirely different meaning. And there are specific criteria that we use to actually determine whether or not a person suffers from a true phobia. Number one, is there a marked and persistent fear that is excessive or unreasonable and that is cued by the presence or anticipation of a specific object or situation? For example, fear of flying, fear of planes, fear of heights, fear of medical procedures, blood, injections, and so on, shots, and so on and so forth. Exposure to the phobic stimulus, so what it is that you're afraid of, exposure to this almost always provokes an immediate, extreme anxiety response. For example, a panic attack, and sometimes fainting. The person recognizes that the fear is excessive or unreasonable. Now, this is an important one. I had a patient once who was terrified, who had a true phobia of cats. She would have a true panic attack if she saw a real cat. She would get extremely anxious if she saw a picture of a cat. Now, this woman loved to dive, underwater diving. And I remember her telling me how excited she was about a trip she was planning to Australia, because there she could dive in a cage and maybe touch a great white shark. And that seemed fine. That seemed perfectly fine, right? In my book, I prefer cats. I prefer cats, right? But she was afraid of cats. She preferred the great white shark. That's because I grew up, I'm from the Jaws generation, right? So the phobic situation is avoided, or when people, or it's endured with intense anxiety or distress. Most of the time, it is simply avoided. If you have a fear, a true phobia of people, like a social phobia, for example, you definitely avoid people. You stay home. You lock yourself up. And so for these people, simple things like doing your groceries, that's highly problematic. The avoidance, anxious anticipation, or distress in the fear situation interferes with your everyday life. That's another example. So it gets in the way of you doing things and going about your life, and you suffer from this. And for younger individuals under 18 years of age, it has to last at least 6 months. And the anxiety and panic attacks and so on can't be explained by another disorder. So specific phobia is really a single diagnosis. There are situations where, for example, someone might be afraid or phobic with germs, afraid of germs or afraid of dirt. One of the things you need to do is exclude another diagnosis, in this case, most likely obsessive-compulsive disorder, where people have to wash their hands over and over again because they're afraid of being contaminated or becoming ill because of germs, right? Someone who would have just a single phobia would be simply afraid of the germs. Now, there are general types. The animal type, like that woman I was mentioning who's afraid of cats. Natural environment types, heights, storms, water, lightning. Anything related to medical procedures, blood, shots, injections, any kind of medical intervention, injuries as well. Situational types, for example, airplanes, a very common one. Elevators, another very common one. And enclosed places like claustrophobia. When we talk about claustrophobia, we're talking about a fear or a phobia of enclosed places. And then there are other types related, for example, to a fear of choking or vomiting or becoming extremely ill and suddenly dying. Now, women appear to be more vulnerable in general to anxiety disorders and more vulnerable in general to specific phobia. There are exceptions, for example. The fear of flying and the fear of heights and the fear of medical interventions, blood, injuries, and shots, for example, are as common in women as they are in men. So it's 50-50. But for the others, women seem to be more vulnerable to the disorder. We have about 100 people here tonight. Statistically, on average, 10 of you at one point in your life will develop a true specific phobia that can be diagnosed. So a diagnosable true disorder, a true phobia. Between 13 and 16% of women, and between 5 and 6 or 7% of men. So twice as likely if you're a woman. And the disorder tends to persist if it's not treated. In fact, remission rate is only about 20%. So 20% get better without any kind of intervention. The others remain ill and phobic if they're not treated. Now that said, phobia does not always get in the way of you. It does not always disrupt your life. And one of the things before you should think about, before you seek treatment, is to what extent this phobia you have gets in the way of you living your life and disrupts your life. Because, for example, if you were afraid of the great African elephant, right? We don't have too many of those here. I haven't seen any. If you avoid zoos, most likely you'll be fine. The rest of your other areas of your life, you'll be perfectly fine. So if it's something that's easily avoidable, you don't necessarily always need treatment. For others, you may need treatment. And that treatment should be psychotherapy. Psychopharmacology does not work. It's not as effective for a specific phobia as psychotherapy. It should be your preferred choice. You should seek professional help with a psychotherapist. And this person has to be a trained professional, a licensed professional, an accountable professional. And this person needs to be able to develop and build what we call the therapeutic alliance, right? One of the best predictors of treatment efficacy, of outcome, for any kind of condition, for any kind of therapy, with any kind of therapist, is the therapist's ability to establish an alliance. And what that means is that a therapist is able to adjust his interventions and his general way of being based on who you are. They tailor what they do and who they are to who you are. Okay? And those therapists who are most effective in treating any kind of mental condition or helping others are those who are able to do this. Okay? Another thing this therapist will do is he will focus on your symptoms. And now he does that for different reasons. It's a way to monitor your progress. It's a way to motivate the person, because as they see their progress, you can score this and you can measure this. You can see how people progress through therapy. It's very motivating. And it's also an important way to respond to the person's initial complaint and initial concern. And the therapist also needs to master a large variety of different techniques. Now, to treat phobia, just like any other conditions, we use different techniques. For phobia, we're going to use relaxation, breathing exercises, for example. That's one piece, that's one part of the treatment. We're going to use psychoeducational interventions where we explain what a phobia is, how it works, what the remission rate is, and the actual outcome and efficacy of psychotherapy. We use cognitive restructuring, which is another important part when we treat phobia. And that very often that focuses on probabilities, right? So you help the person rethink the situation. So for the fear of flying, if someone's afraid of planes and afraid of flying, you're going to tell them, for example, that the probability of dying in a commercial plane crash is 1 in a million, right? That puts things into perspective. When we're phobic, we forget that. But 1 in a million. You also tell them that there are 66,000 commercial flights without any crash every day in Canada and the States. That also helps to put things back into perspective. You'll tell them that plane crashes receive 8,100% more media coverage than the same number of deaths caused by cancer. Nobody cares about cancer. Heart disease, nobody cares about heart disease. Firearms or car accidents. So that also helps to put things back into perspective. Now, there are different therapies out there. I'm sure you've heard of psychodynamic psychotherapy, existential, experiential psychotherapy, humanistic psychotherapy, psychodynamic psychotherapy. They all have one thing in common. All of these you'll find in all these different treatment modalities, but the key technique in all of these treatments is exposure. There is a point in the treatment where the patient has to learn to confront his or her fears. There's a point where the person has to be in the situation in front of the stimulus that creates so much anxiety and learn to tolerate that anxiety to the point where it becomes manageable, right? We call it habituation. So you become accustomed to the stressor and you're no longer anxious. And so every therapy, no matter what the modality the therapist uses, will have this part, the exposure piece. You can do exposure, that means putting the person in the situation, have them face their fear or the object of their fears or their phobia. You can do that in different ways. You can do it gradually, for example. So you can have the person, they start with baby steps, and as they get comfortable, you make it a little more anxiety-provoking and so on and so forth. Or you can do it using a technique we call flooding, which is basically where you overwhelm the patient with the stimulus until they become accustomed and habituated to the stimulus. Now, there's a lot of research in this area, and if you happened one day, which is not something I hope will happen, but that if you didn't need to seek therapy for this at one point in your life, there's a lot of research that indicates that gradual exposure is more effective than actual flooding. Right? So it should be baby steps, and the person should gradually expose you for longer periods of time and to more anxiety-provoking objects. You can also do the exposure alone with your therapist, or you can do it with your therapist and a significant other. Right? And we know that getting someone involved, a significant other, in your treatment also increases the efficacy of the treatment. So if you happen to seek help, try to get your husband, wife, or friend involved. It's something that will increase the efficacy of the intervention. Exposure can also be done with a way out or without a way out. For example, fear of flying. There was a time where they would treat the fear of flying with a flight simulator. People would climb onto a flight simulator, they would shut the door, and then they would take off. Right? And it would move, and then you would have your visuals, you would have your screen, and then the audio, the engines racing, and so on and so forth. And there are different ways of doing this. With a way out, that means the person has, for example, a panic button where they can just hit the panic button, and then the simulator will suddenly stop, and the person can leave. Or you can do it without a way out, where the person cannot control the simulator, and they have to remain inside the simulator until it actually stops. Now, there was a time when we thought the latter was most efficient, where people had to stay in there whether they liked it or not. And now we know that it's better if the person actually has control, if they have a way out. And what happens normally is people don't use the panic button. They don't stop the simulator. But knowing that they could, if they wanted to, is extremely reassuring, and that is enough for them to keep going and push themselves a little further. Exposure can also be done using your imagination. So your therapist will have you imagine whatever it is you're afraid of, and then rate it on a scale from 1 to 10, describe it, how anxious you are, describe what you see, just using your imagination. That's one way of doing it. Or you can do it in vivo. In vivo means you do it live. So if you're afraid of spiders, for example, there would be a point in the therapy where you would be exposed to at least pictures of spiders at the very beginning, because you start gradually, and then pictures of larger spiders, and then pictures of maybe 2 spiders, then pictures of spiders with teeth, to the point where eventually you might actually see a real spider, and then slowly get closer to the spider to the point where you can actually hold it and play with it, which is always a problem, to be honest, for therapists. Because one of the things, I went to school 11 years to become a university, 11 years to become a psychologist. No one ever taught me how to handle a spider. And one of the things we noticed when we were doing this research originally, using real animals, is our research assistants didn't like it. Why? Because there was a point where the client became more comfortable than one would normally be with a spider. So they could actually end the session playing with a tarantula, right? And they felt comfortable. Now, obviously, that's a successful treatment. But then you would have the research assistant sort of grab the thing like this, right? Or just push it into the cage, right? So there's a point where the treatment is so effective that people actually become more comfortable with it than you are. There's a problem with in vivo exposure. We don't always have what we need handy. So not every therapist has a spider or a snake tucked away in a drawer or a closet. I don't have a plane in my office, no flight simulator. I don't have any of that, right? So one of the things people have been doing is using an alternative to in vivo exposure. Now we know that in vivo exposure is more effective than using your imagination. If you can actually interact with something real, it's better than just using your imagination, right? But there are other ways of putting you in front of something that seems real enough, and that's virtual reality. And the reason I got involved in this is I just received tenure recently, and as some of you may know, tenure track is a lot of work, and of course you have no social life and no hobbies and no friends and so on. And people said, well, you need leisure, you need some kind of fun in your life. What do you do for fun? And I work. So I decided to combine the two, right? Video games, right? I do research on video games. I do research on virtual reality. Now, what is virtual reality? Here's a fancy definition. It's an application that makes it possible for the user, yourself or myself, whoever seeks treatment, to navigate and to interact in real time. That's very important. It has to be in real time with an environment in 3 dimensions. So that's also very important. It has to be 3D. In 3 dimensions generated by a computer. In other words, again, this is exactly, if you think of yourself or your children, that's exactly what they do on the weekend or every night of the week. They play video games. These are video games. If you're familiar with these action video games, right, which I wasn't up until recently, you'll probably know this game. These are just stills taken from a game called Max Payne. Certainly one of the most popular action video games out there right now. So what's Max Payne? It's a video game, and you're a character in there. You're Max Payne. You walk around. You try to find things. You look for things. You meet people. And, of course, you shoot people. Right? The bottom line is you go around and you shoot people. Now, another popular game is Final Fantasy. And in this game, you're a character, and you go around, right? And you also shoot people. Grand Theft Auto is probably the most popular game with teenagers. In this game, you go around and you steal cars, and then you shoot people, or you shoot people to steal their car. There's another one. There's quite a few of these video games, to be honest. Another one is Unreal Tournament. You may have heard of that. And in that game, you also go around and you shoot people. Now, what do all of these games have in common? No, that's not what they have in common. What they have in common is that that's right. You're a person and you are in a virtual environment. You can walk around. You can climb over things. You can go into tunnels. You can climb on top of buildings. You can run, walk, jog, hide. You can meet people, interact with people. Right? You can do all sorts of things. So what we have actually are different virtual 3D environments. Environments that we can just take, modify. You just remove the shooting, basically, and you have these environments that you can completely control and use to help people face different fears. Fear of heights, the picture at the very top. This is somebody standing on top of a building looking down, right? So this person in this environment can actually walk around on top of a building. A fear of closed spaces, for example, that tunnel we just saw, or a fear of spiders, which is the other snapshot we saw. What you have here is a static environment. What I mean by static, let me just find this shark here. There he is. Okay. This is a static environment. What that means is that I can just look around. Right? I can't move myself. I can't do anything. This is just a demo. right? So I can see the shark. I can actually tap his nose if I want to and make him go away. Right, there he goes. He didn't like that. There you go. Goes away. And I can look around. One of the things you need to do when you're using virtual reality to treat individuals is to give them a sense of presence. They need to feel like they're inside the game. Okay? And it needs to feel real, or at least real enough. We have different ways of doing that using virtual reality. The best one is what we call the cave. We happen to have one in Canada. It's situated in Gatineau. And the cave is basically a room with 4 walls and a floor and a ceiling. But each one of these walls and the floor and the ceiling are projective screens. So you can project images onto this. So you walk into this virtual environment. And what we have here are just demos. It looks, pardon me, artificial because our vision is kind of cute here. You need special goggles to actually see this and make it feel real, right? But we have somebody who's afraid of dogs at the very top, trying to lean down and pet this big dog. And the dog can move around. You can move away from the dog. You can follow the dog, and so on and so forth. You have someone here who's entering a plane, right? So he's actually going to walk into this plane virtually, sit down, buckle his seatbelt, and eventually he'll hear the engines going, and then the plane will take off. Here you have 2 scenarios involving apartments, and these scenarios we use to treat arachnophobia, so a fear of spiders. We can control, for example, how many spiders are on the counter, how scary looking, how big they are. Or we can use it for social phobia, for people who are afraid of social interactions, where we just put people, virtual people, in these rooms, and you can actually walk up to these people, introduce yourself, and so on and so forth. Now, the cave is definitely the best way to do it. The only problem is it's extremely expensive. So what we do is we instead use other devices, for example, a head-mounted display, which is basically these goggles right there. They're goggles, and inside this goggle you have a projection screen. So you put it on, and then you have a screen. It kind of comes around like this, and you can see this. So you're inside the game. You can see this virtual reality. You feel inside the game. If you turn your head, well, the vision moves just as accordingly, right? We also use a glove, which looks like this. Kind of looks like a spider, doesn't it? So you just put it on like this. Right? So you need at least one of them. You have your goggles, and then you have your gloves. And this is extremely important for a number of reasons. First, it allows you to touch things in your virtual environment. So, for example, if there's a spider, you can actually reach out and just push it away. Right? You can move objects around. Some people are starting to use virtual reality to treat eating disorders, for example. So how people relate to actual food in this environment. Get them accustomed to the idea of eating so they can actually grab an apple in this virtual environment without being disgusted, which is something that happens in certain eating disorders. Another reason why the glove is extremely important is also because it gives you a sense of presence. Now, these are just video games. They're not perfect. When you watch a video game, they look real enough. They don't look perfectly real. So you have to trick people into believing that it's actually real. And there's different ways of doing that. And the glove is one of these ways. Why? Because as you move your hand, as you reach out, for example, to touch something, you actually see yourself reaching out in this virtual environment. And what this does is it creates a bridge between what you see, your virtual environment, and your real environment, your movements. So as you reach out, you can move your hand, and inside your goggles, you'll have your environment and your hand moving around. So you can move things, as I said, or just push them or shoo them away. Let me just get this off here. Another thing that's important, again, other ways we use to create a sense of presence and to trick people into believing that what they actually see is real is we have other ways of creating bridges. For example, a fear of heights, right? So the person might see in their goggles stairs with a handrail, and they can see their hand reaching out towards the handrail. And to make it feel real, what we'll do is we'll use an actual real handrail in the room, and as the person reaches out in this virtual, does this make sense so far? As they reach out in their virtual environment, we'll just put the handrail there so they actually can grab onto it, and that creates a bridge. It gives them a sense of presence, so what they see feels even more real. Fear of spiders, we'll use, here's my little friend Willie here. We use actual little rubber spiders, okay? And for fear of spiders, touch is extremely important. Virtual reality alone is not enough. You need to actually be able to reach out and touch it. I didn't bring it, but he has a little jacket, a little furry jacket, because the fur actually increases the anxiety, and that makes the treatment more effective. Fear of flying, another way we have. One of the things people need to be tricked into believing that what they see is real is they need some place to sit, obviously. They need a seatbelt, right? One of the things we realized is when people sit down in this virtual environment and the stewardess says, please buckle your seatbelts, they would reach out like this and look for their seatbelt. Of course, we didn't have seatbelts. These are just normal chairs. But just adding a seatbelt that they could grab onto and then they would buckle up, it felt even more real. And what helped, believe it or not, the most was to make some coffee, right? Yeah, if you think last time you were on the plane, when you walk onto the plane, what does it smell? It smells like coffee, because they want that coffee ready by when the plane is up in the air. So we'd get coffee going, and just that smell already, walking into the room, just the smell, knowing that somehow they would be on a flight, a virtual flight, was enough to create the anxiety. Okay? But one of the things you have to understand is that when you have phobia, or when you have any kind of anxiety disorder, the phobia, the anxiety, is what makes it look and feel very, very real. So the graphics are not perfect. We use very powerful computers so that there's no, for example, no delay. When you move your head, we don't want any delay between you moving your head and what you actually see, right? But with the anxiety, it doesn't really matter, because just the idea that you're going to be faced with the phobic object is enough to create the anxiety. And that's what makes it always feel so much more real. And that's what makes the therapy actually effective, using virtual reality. Now, I debated whether I should present an actual demo of and then I was told there's a lot of tech problems, and there's another problem as well, which is we use these demos, these environments, for research. And one of the things I can't do is I can't burn my environments, because we might actually use this at one point, and this is televised, so we can't use these environments, show them to the general public, and then use them for the research as well. Just like if you think in the 70s you had those ink tests, right, the Rorschach, those old projective tests with the ink splattered. Normally a professional is not supposed to show you any of these in public because it burns the test, right, and it loses its validity. So I decided not to show anything. But I can tell you this. Virtual reality, we know for sure, is as effective as in vivo exposure. It is, in fact, a form of vivo virtual exposure, so it's as effective. The advantages are it is extremely available. This is what we need is just goggles, those goggles I showed you, the glove, right, one of these, and a gamer, which is a very powerful laptop computer with a very powerful video and audio card. That's all we need. So it's very convenient, can be moved around. It's easy to have access to. I said this before. When you go to school to become a psychologist, no one teaches you about handling spiders and snakes and so on and so forth. Nobody really wants to, anyway, to be honest, right? And if you become accustomed with the technology, you can actually create these environments for the person without actually having to take care of spiders or feed them and so on and so forth, because believe it or not, you do have to feed these things at one point, right? You have complete control over the stimulus. That means that you can control the intensity of the anxiety. You can make it a bigger spider. You can make it a smaller spider. You can have it run away, come closer. It could actually run after you. We can do that. It can be furry. It can have teeth and so on and so forth. We can have one or just or thousands. So we have perfect control over the stimulus, and the patient, the client, has perfect control as well. They can just stop it anytime they want. And as I said earlier, this is an important factor in any kind of therapy. The idea that you can stop when you want. You won't. You'll go ahead, but the very idea that you can just stop when you want is enough to reassure you, and then you'll just push it a little further. Access. If you, complete control, confidentiality. Think of someone who's afraid of the subway, okay, which we've had before, someone who's afraid of taking the subway. So this person at one point needs to take the subway with the therapist. that means you need to go into the metro. And these are people who have true phobia, so they also have, for example, panic attacks, right? So you're in a public situation, and you have a panic attack. Okay? And so this is, of course, it raises problems in terms of confidentiality, and it's an added stressor. Or anything along the lines of social phobia, where you might end up going to a restaurant with your therapist just to sit there and have a coffee, right? But what happens if you have a panic attack or if you faint? So people will become very anxious about this, and we don't have this problem, obviously, with virtual reality. And last but not least, it is much cheaper than in vivo exposure. You don't have to feed the animals. You don't have to take care of the animals. You don't need to take a ride to the airport or to some airline company to find a flight simulator. It's a lot of wasted time, and it's a lot of resources that we don't have to invest in when you use virtual reality. I'm going to end it with this slide, and then we'll open it up for discussion. This is a slide from Aurelius. He says, "Never let the future disturb you." And I find it to be a very pretty saying. Never let the future disturb you. You will meet it if you have to, and that's important, only if you have to, with the same weapons of reason which today arm you against the present. Now, if for some reason or another these weapons are not enough for you, we can certainly borrow from Max Payne and Grand Theft Auto, because they have plenty of weapons to go around. Thank you.